Hi everybody, I hope you're having a great time and learning what we all need during this time at the virtual summit. I'm here at the summit as a vendor to tell you about my dry needling certification program, but I'm also here as a GrowthX member and have found the BPTM crew to be an invaluable resource. So here's to learning more great content and making the most out of what we learn. Let me first talk about my background and my involvement in dry needling. I've been a PT in private practice since 1994. Like many of the older PTs in the game, I've gone through many cycles during my career that have reinvigorated my passion for the profession. Some of the new skills I've learned started out being fully implemented in the practice as a first level intervention. Over time, they would become simply another tool in the bag to use as needed. As clinicians, we need lots of tools like that to address the variety of conditions that we come upon. Examples of those tools could include instrument-assisted soft tissue mobilization, cupping, blood flow restriction therapy, joint manipulation or mobilization, the Haynes Method, Cyriax, Mulligan, total motion release, craniosacral therapy, among a long list of other treatment approaches, all of which have their place in the therapist's tool bag. Then there are a wide range of modalities that we can have in there: laser therapy, ultrasound, diathermy, heat and cold, vasopneumatic, paraffin, fluidotherapy, electrical stimulation, and that list goes on as well. Again, these are all good tools to have at your disposal in the tool bag. I was first exposed to dry needling 7 years ago and went on to gain certification in 2 different methods. Each certification program series had their pros and their cons. And I would venture to say that any dry needling program out there will provide you with an entry level of competence in performing dry needling. What those programs did give me was the awareness that through dry needling, we as clinicians have the ability to finally have a direct communication with the tissues that we've been attempting to elicit a change in since our very first day of professional education. We have a responsibility to be very adept at the specifics of the anatomy we're attempting to manipulate through dry needling. I learned very quickly that I had to immediately undertake teaching myself and learning anatomy all over again. If we are going to use dry needling effectively as a treatment tool, then we must be an expert in the anatomy that we are attempting to manipulate. In an effort to address the neuromuscular skeletal problems that I'd been treating through manual therapy for years, I embarked on a 5-year journey to rebuild the dry needling approach from the ground up. The end product of that journey is the Haynes Method of neuromuscular dry needling. Why did I decide to deconstruct and to rebuild? That's a good question. When I first became certified in dry needling, I implemented the treatment approach to every patient that consented and that was not contraindicated. Over the next 5 years, I saw a 300% growth in patient volume and staff hiring. It wasn't uncommon for me to needle 30 to 40 patients each and every day. Don't get me wrong, it was a great opportunity for me to further develop the method by seeing such a large volume of patients with such a wide variety of conditions. The challenge I was faced with, however, was how do I transmit everything that I've learned to the rest of my therapists? That was a monumental challenge. The origin of the Haynes Method was an effort to teach my therapists what and why I was doing and what I was doing with dry needling. Getting them all certified in the method greatly improved the flow of patients in the clinic and increased outcomes and patient satisfaction tremendously. Additionally, it greatly enhanced my ACE, my authority, celebrity, and expertise in my community. We now have patients that will frequently travel 1 to 3 hours each way to get some of the gains that they have heard of through simple word of mouth. In this course series, I will teach you the basics of how to dry needle. And we'll implement a proctored laboratory session or sessions that will also give you the opportunity to practice and demonstrate competency in the skills. But that is a skill that can be taught and learned through any of the course offerings that are available out there. My goal in offering this course series is not to simply get people to sign up for and take the introductory course. While I do want to see more people using dry needling as a treatment tool, it will never be used to its full potential until more clinicians are moving away from single muscle needling as a treatment. The goal of the course series is to give each of you not just the ability to safely needle all the muscles, the tendons, ligaments, and nerves in our purview, but how to group them into staged treatments based on the response from each session as outlined in specific protocols for most every clinical diagnosis that we'll see on a daily basis. The goal is to give you the guidelines to become expert dry needlers to further the cause of our professions and as autonomous professionals capable of providing the very best intervention for neuromusculoskeletal conditions and to get our patients back to normal without the need for unnecessary drugs, injections, or surgery. You want to make sure, go ahead and lift up a little. Very good, there comes the tendon coming up. And I can palpate it right there. Very good. And then we've got Popliteal Crease. So you can relax. Again, her palm width. You can come up. I'm going to go lateral. To get to the fully into the other, the rest of the muscle, I would want a longer needle. As I'm doing adductor magnus in a minute, which we will, I'm going to catch some of it as well as I'm coming posteriorly. But for practice sake, that will get what we're looking for.
This was about 45.
Up to 45 degrees. I may actually find that I need to come further lateral to get more depth down into the bicep. Here we've got a safe location. We're not going to be hitting the neurovascular bundle. So, and that's what I'm going for, is to make sure we stay away from that. Clinically, I might treat it here. I may come all the way up and catch it even up onto ischial tuberosity to get that response.
At ish 2, would you still be going away, or are you going like after?
So for boom, hamstrings also responsive. So what I also wanted to do was take a little bit of time. I know we're talking about dry needling and how much, I'm very passionate about dry needling as a clinician and what it can do for treatment of patients. And there are absolute positives that go along with that. But as business owners, as practice, what we really want to know is, what is the advantage of dry needling for our clinicians? What are the benefits as an owner of investing the money into this education, into this training? I know. So with me is also Ashton Haynes. Ashton is number one, my wife. She's also my partner in crime in all things fun and otherwise. But also she's our practice manager for our clinical practice. And so what we're wanting to do is talk a little bit about the benefits from a practice standpoint. One thing we talked about a little bit earlier was the benefit of having our clinicians certified in the same approach through the Haynes Method and its impact on continuity of care.
Yeah, so I'll touch on that just a little bit. It's been really nice that as my front office staff is scheduling patients, they're able to schedule them across all of our therapists. It's not like one of them is specialized in dry needling and the others are not. So it's less that my front office has to concern themselves with as far as, scheduling and maybe putting patients on the wrong therapist that can't perform the service. So it's been really helpful. It's also really helpful when I have a therapist take a vacation or even if they have to call in sick or something, that I don't necessarily have to just completely cancel their appointment because someone else is trained in the same method that they are. So I know that the patient is going to get the same level of care regardless of which therapist treats them.
I know that when I was in the office, I was the only one certified in doing dry needling. There were times when I might find that I was being used basically as a modality. I was being used to dry needle different, maybe 30, 40 people a day that I would dry needle myself. And so the certification process, once I put it into place, it was probably, now I put my staff on an accelerated program, but over the 12 months that we took, and it was actually less for us, but over a 12-month period, one of the nice things is all of the staff were on the same in the same mindset as far as the educational piece, and they were really reinvigorated over what they were learning, both in dry needling. But the really nice thing about dry needling is the carryover that you get with all other aspects of clinical practice. And by that, we definitely have to relearn all of our anatomy. Whenever I'm teaching a dry needling course, one of the things that I tell people is that dry needling is fantastic, but without relearning all of anatomy, you just won't get there. So in traditional physical therapy, we look at, let's say, the origin of the rectus femoris. Theoretically, we like to know where it is and, its impact on movement of the hip and that muscle on extending the knee. However, if we're going to dry needle that tendon as it attaches onto the anterior inferior iliac spine, we really have to know exactly where that is. And it's really fun as a business owner, as a practice owner, to watch each of the clinicians get reinvigorated about their anatomy and get that passion back. And actually, you might have something to add to that.
Yeah, it's been really fun watching. Like Luke said before, he's been working on his dry needling certification program for about 5 years, and he started dry needling about 7 years ago. At the beginning of that, he started relearning all of his anatomy, and he pulled out all of his books, and he was studying all the time, and he started quizzing our therapists fairly regularly, and they had forgotten all of the innervations and things like that. Once they got their license, they just stopped remembering it. But now, when Luke quizzes them, most of the time they have the answers, and it's like they've been reinvigorated not only to the anatomy and physiology of the human body, but also to their profession. One of the really cool things is when we get a patient in who's been in chronic pain for 20 years. They've tried all these other things. They've tried injections. The surgeons have been trying to get them to have surgery. And one of my therapists will dry needle them. And after the first visit, they will have noted decrease in pain. And it's not only good for getting testimonials and reviews from the patients, but it's been really good for my staff morale, because it feels really good to make that difference and to change someone's life for the better. They feel like they're really getting to help someone now. And getting people out of pain has just, like, again, I use this word, reinvigorated them to the profession and to work, and it's been really nice.
And so it's definitely a big win, a big plus for staff morale, staff excitement about the profession. It is also a fantastic way that we have seen just tremendous growth. And just a side note, we've been Growth X members for right at a year. Is that right? So we had really seen significant growth even before we came on board with BPTM and the growth, or Product X, now Growth X. And so a large part of that was due to our work with dry needling. One of the nice things is with the staff dry needling, we finally we are frequently, Ashley mentioned, people with chronic pain 20 plus years. That's a very common occurrence that we see. And so we are one of the few people that when they come in, we're usually the first person who's ever actually touched their pain. And we get a big response from our patients when we do that. And that's one of the things that really lets us get really good with our ACE, our authority, our celebrity, our expertise, because we touch the pain. Another nice thing is it really lets us put it really reinforces our manual therapy approach. We're going to do a lot of manual therapy beforehand. We'll probably, after we dry needle, we're going to come back in and do that as well. So it's a really nice segue to work through the 3 phases of healing by really knocking down that pain up front with that first one. And so it really keeps our staff focused on that mantra of the 3 phases of healing and moving forward with treatment and completing their plan of care. But again, just reiterating, the ACE piece in the community has been significant. Prior to BPTM, quite honestly, we did very little in the way of spending money on marketing, and it really helped us out in growing our practice by using the dry needling approach. And again, getting those, now that we're in GrowthX, really focusing on our reviews, our testimonials. That has been such a big piece to getting that, because we see big results, big changes almost immediately using the approach. And I think both, like you said, both for our patients and for our staff, it's a win-win for everybody.
Okay, so let's talk about some more information here. As previously stated, my goal with the Haynes Method is not to have large numbers of people take an introductory course and then never proceed to advanced studies. I can gladly provide you a list of organizations that specialize in teaching introductory basics to learn how to stick needles in muscles. At the end of the day, dry needling is both an art and a science. To become an ace in dry needling, it takes a commitment from the practice and the therapist to achieve that goal. The Haynes Method certification program is a 64-hour program spread over 8 days. The initial introductory course will teach your clinicians the principles and history of dry needling, safety practices, functional anatomy, and palpation labs, as well as labs incorporating dry needling in the muscles and tissues that are appropriate for entry-level dry needlers. Have no fear, your staff will have training and protocols in hand to begin treating the most common cases that you'll see in clinic with dry needling on the very first day. Treatment protocols for the upper axial, appendicular, and junctional zones is one of the advanced courses in the Haynes Method of neuromuscular dry needling that outlines the advanced protocols that build upon the principles taught in HMDN1, or the introductory course. HMDN1 must be completed before attending HMDN2. HMDN2 upper focuses on advanced protocols that apply to the upper axial, appendicular, and junctional zones and their application to a variety of common conditions, functional impairments, and diagnoses. Critical to competence and confidence with dry needling will be functional surface anatomy palpation labs and practical dry needling labs in each body region. The treatment protocols for the lower axial, appendicular, and junctional zones is one of the advanced courses in the Haynes Method of neuromuscular dry needling that outlines the advanced protocols that build upon the principles taught in HMDN1. HMDN1 must be completed before attending HMDN3. HMDN3 lower focuses on the advanced protocols that apply to the lower axial, appendicular, and junctional zones and their application to a variety of common conditions, functional impairments, and diagnoses. At the conclusion of day 3 of both the upper and lower advanced courses, there will be a written and lab practical examination. In order to earn the certification in Haynes Method of neuromuscular dry needling, the written and lab practical examinations must be successfully passed, at which time your staff will be granted the CHDN credential.
Another thing that we try to look at whenever arranging our course schedules is class size. It's incredibly important to have a proper amount of instructor to students in each of the courses, safety with the approach, and equally important, the ability to provide a hands-on and very close assessment of needling location and protocol development is key to the hallmarks of this program.
The Haynes Method is tailored to give each clinician the opportunity to fully integrate dry needling as a first-level interventional modality into daily practice through completion of each of the course offerings. The course content was not designed with the intent of meeting each state's minimum requirements to allow the practice of dry needling. It is incumbent upon each practicing clinician to determine what the requirements are for your state and to make sure that you meet those requirements. There are several other teaching institutions that are geared towards that goal. The goal of the Haynes Method is to provide the very best information and training to enable a furtherance of dry needling as a treatment approach. My goal is not to have a large number of clinicians taking an introductory course in dry needling and then not follow up with the advanced coursework. The purpose of any introductory course is to expose the student to the concepts and give them the tools to start practicing the technique. Mastery of the skill set and the tools can only be achieved after repeated use of the tool in daily practice and in a complete immersion in the concept. In my personal private practice, use of dry needling and the advanced concepts has been a game changer in patient outcomes and satisfaction and overall treatment time. I had the luxury of unrestricted use of dry needling to develop the needling approaches for each muscle, tendon, ligament, nerve, and regional or diagnosis protocol. I developed the Haynes Method to share the successes that I've had during the development with other clinicians that have not had that access to the treatment opportunities. Something very important with dry needling, we'll discuss this briefly, are the danger zones. Definitely some areas without being extremely prolific with our technique that we want to stay away from, and we'll talk about those here. Number one, the atlas and axis, the suboccipital region, just definitely some structures that we want to avoid, say in the event of a Chiari malformation. We want to stay away from that area. In the supraclavicular triangle, definitely some structures that we have to be cautious of. That being said, with advanced training, we definitely get into this area, especially dealing with the anterior scalene. In the thoracic spine and the rib cage, this is definitely an area we get concerned about. We do a lot of dry needling in and around the thoracic spine. However, we have to be aware of our distance from the spinous process to avoid a pneumothorax if we needle in between the ribs or away from the lamina. And at the iliac crest, there are some structures that we do needle there. However, we have to be cautious of our needle angulation. As you can see, there's a lot of visceral contents that we definitely want to avoid. At the TL junction, one thing that we notice in this area is that there is a significant change in width of the lamina itself, which we frequently use as a backdrop for our deep spine needling. Missing the lamina can end up resulting in needling into the lungs, the diaphragm, or the kidneys. At the femoral triangle, there are structures that we do needle in this area. However, being the location of the femoral neurovascular structures, we want to be cautious and aware of where those structures lie when we do needle. In the sacral, the coccyx, the buttock region, the main issue there is the sciatic nerve itself. Our protocols are designed to ensure that when applied properly, the risk of hitting that is minimal at worst. Easy to avoid when you apply the principle. The popliteal fossa, again, we're wanting to avoid that neurovascular bundle in behind the knee. Similarly, at the cubital fossa, a lot of neurovascular structures there. The ulnar nerve, want to avoid any sort of compromise with that. That also being said, there are protocols that are developed to specifically let us target the ulnar nerve. The Haynes Method of Neuromuscular Dry Needling Seminar Certification Series is a 3-part program, with course 1 being 2 days and courses 2 and 3 being 3 days, including the certification exam and the practical if the participant has completed all 3 components. During this series of courses, we teach over 200 specific muscle groupings, 79 tendon and ligament, and 21 tenosynovium techniques on each side of the body, as well as 87 diagnosis or injury-specific protocols and 35 peri or epidural protocols. For the 2020 course offering, that now totals 420 specific dry needling interventions across all 3 courses. The Haynes Method starts with a course that covers the principles and the history of dry needling, safety practices, functional anatomy and palpation labs, as well as labs incorporating dry needling in the muscles and tissues outlined in the syllabus and identified in the labs. The second and third courses explore specific treatment protocols developed for treatment in the axial, appendicular, and in regional junctional zones for the upper body and then the lower body. At the conclusion of HMDN 2 or 3, those participants who have successfully completed the 3 courses and wish to demonstrate advanced clinical competency can sit for both a written and a practical examination, which, upon successful completion, will lead to certification in the Haynes Method of neuromuscular dry needling. The upper body protocols addresses the following diagnoses: suboccipital or headache problems, problems with TMJ, Bell's palsy, upper traps, the tension symptoms, anything at the cervical region or at the CT junction, and then also at the ST junction. We have protocols specific for the SC joint and the AC joint, in the thoracic spine as well, and then for symptoms related to a thoracic outlet syndrome. We also specific protocols for the rotator cuff tendinitis. We target specifically the subscap, infraspinatus, supraspinatus, teres minor. Also look at tendinitis of the bicipital, either origin or insertion, and then impingement problems such as with subdeltoid subacromial bursitis. Further distally, treatment protocols for tennis elbow, golfer's elbow, cubital and carpal tunnel syndrome, thumb OA, trigger finger, de Quervain's tenosynovitis, and then a long list of potential sites of tenosynovitis in and around the wrist itself. For the perineural approach, the nerves that we've targeted, the median, the radial, and the ulnar. We also incorporate the posterior antebrachial cutaneous nerve, the musculocutaneous, the lateral antebrachial cutaneous nerve, the axillary nerve, medial brachial cutaneous nerve, the medial antebrachial cutaneous nerve, the anterior branch of the medial antebrachial cutaneous, and the posterior branch as well, the supraclavicular nerve, and then around the head, the supraclavicular, then the greater occipital, the lesser occipital, the greater auricular, and then the facial nerve, all come into play with specific dry needling protocols or in conjunction with other syndromes that we're treating. In the lower body, we'll start at problems specific to the TL junction. Very common, one of the ones we treat more than anything, is at the lumbosacral junction. Specific protocol to treat sacroiliitis, and then the lumbosacral pelvic junction, which is that pain that radiates a little bit lateral towards the greater trochanter. Treatment protocol for the quote sciatica symptoms, a specific piriformis syndrome protocol, people with trochanteric bursitis, an aggressive dry needling protocol for that, as well as the IT band syndrome, good treatment protocol for anterior hip or osteoarthritis or impingement of the anterior structures, protocols for adductor strain, hamstring strain, and then quadriceps tendinitis. Moving further down into the knee, protocol for patellar tendinitis, patellar bursitis, the suprapatellar, the subcutaneous, or the infrapatellar. For knee osteoarthritis, not listed here, but also a novel approach for treating the knee by treating the genicular nerves. Another important one that gets used very frequently is treatment of the pes anserine bursa. Good protocol for the Baker's cyst, and then the MCL lateral collateral as well, and then a more functional common approach to the runner's knee and shin splints. Moving further down into the ankle, the lower leg and the ankle, approach for dealing with perineal tendinitis, your lateral and medial ankle sprain. There's the Achilles and the malleolar bursitis, and then obviously a lot of work on the protocol with plantar fasciitis, both proximally in the lower leg and into the dorsum or the plantar surface of the foot as well. Tenosynovitis, most common one, Peroneus longus and brevis, but treatment approaches for the other tenosynovium as well. Novel approach for dealing with pelvic floor pain and incontinence, and then a general approach for dealing with peripheral neuropathy. Lastly, the perineal protocols for the lower body, the superior cluneal nerves, the lateral cutaneous iliohypogastric, and the anterior cutaneous. Lateral femoral cutaneous nerve, the genitofemoral nerve, obturator, muscular branches of the femoral nerve, the posterior femoral cutaneous, and then further down the tibial, lateral sural, medial sural cutaneous, the common perineal, deep and superficial perineal nerves. And then further down, the sural nerve saphenous and the dorsal cutaneous nerve on the dorsum of the foot. Again, these are used either in isolation because of a restricted, maybe it's an impingement or entrapment of the nerve itself, or in conjunction with another functional problem that's previously covered in just specific protocols.